meaningful dialogue with many Indigenous people and nations, and especially our political leaders, and that the Minister of Health talks not only in terms of provincial and territorial governments, but also our Indigenous governments that have some sovereign rights to having their voice heard here on this legislation. So it's vital that we roll out this new program very carefully, that we really consider the context of existing benefits, particularly through the non-insured health benefits that present the right of the status First Nations and Inuit beneficiaries in Canada to provide for medications for treatment of diabetes and other pharmacological care, but not all of them. So it is at the detriment of the individual. It also remains unclear whether NIHB and the new Pan-Canadian Pharmacare program will be responsible for providing medication coverage to these individuals, but as the minister spoke earlier today, that all the programs would kind of remain in place, so we believe that that would be helpful. The coverage of medications for First Nations and Inuit can be bureaucratically burdensome, and we know this. Individuals and healthcare providers on reserve are already really administratively overwhelmed, so we need to ensure that the policy is reducing those burdens administratively so that our providers can directly impact patients and deliver patient care in a good way so that we don't need to burden individuals with getting their medications covered. We also want to make sure that there's a comprehensive list of medications allowing for both the prescriber and the patients to be advocates in the healthcare journey of their diabetes management. And of course that we want to steer away from a two-tiered healthcare system that, only the best and strongest medications are only available to those with deep pockets, with privilege and secure employment with strong health benefits. So in that same tone, we want to ensure that no Indigenous person is left behind, because having Métis individuals not including in the NIHB means that Métis individuals providing their care will have much greater access through this bill. And we have to remember that when we walk forward in this legislation. And we need to be at the bare minimum or equal at the bare minimum of equal or better than current coverage for all Indigenous people in Canada. And we must make sure that we are working together to ensure that there is that access, whether that is brand name medications for diabetes care when the generics are not available, again, supporting timely access and ease of use for Indigenous people so that, those living with diabetes can keep their healthy blood flowing now and several generations from now. And as an Indigenous woman, I'd be remiss of the opportunity to also comment on the contraceptives. As someone who had to use 3 IUDs to get my last one successfully put in, IUDs are quite expensive, and that would be not possible for me had I not had some support in place to be able to do that and make that a reality. And so that all Indigenous people are able to access whatever form of contraception they need to determine what is best for their own person, and that the funding should be provided for each of those types without exceptions, just as it should be with diabetes cares, as it's an extremely personal journey. So we look forward to a Canada where First Nations, Métis, and Inuit have equitable access to life-saving medications, although more consultation is required to move forward in a good way. We really invite further collaboration on this vital project to ensure that no one is left behind. We want to ensure that everyone from our Indigenous elders, youth, lived experience people, Indigenous nations, governments, and politicians are adequately involved in the decision-making process of this bill, not just, like I said, our provinces and territories. And let's continue to work together in a good way to ensure that we are raising health outcomes for all Indigenous people in Canada, representing a significant step forward in addressing social health inequities across Canada.
Ms. Thériault, please.
Merci. Thank you. Thank you for your attention.
Okay. Thank you. Dr. Francoeur, representing the Society of Obstetricians and Gynecologists of Canada. Welcome. You have the floor.
Thank you. Mr. Chair, members of committee, bonsoir. My name is Dr. Diane Franqueur. I'm a practicing obstetrician and gynecology, as well as the Chief Executive Officer of the Society of Obstetricians and Gynecologists of Canada. I'm here today to discuss the aspect of Bill C-64 that proposed to offer universal coverage of a full range of contraceptives for Canadian women. Specifically, I wish to highlight why this measure is important and long overdue, why it's not just a woman issue or a nice-to-have measure, but a necessary economic policy that benefits all of society, and why we hope as legislator will ensure coverage of all forms of birth control are included in the final bill and that it passes without any undue delay. Today, somewhere in Canada, a woman will have to choose between buying grocery, paying her electrical bill, filling up her gas tank, or paying for her birth control. It's no secret the rising cost of almost all goods and services have become a significant burden for many Canadians. But 9 million women of childbearing age in Canada bear the additional cost of preventing unintended pregnancy, a basic need which often flies under the radar, but which is no less fundamental to the way of life of millions of Canadian women. Contraception allows women to plan their lives, their families, and their pregnancy. They are more likely to finish school, they participate more fully in the workforce, they enjoy more economic stability, and they have healthy pregnancy when they do choose to have children. Canadian women spend on average 30 years of their lives shouldering the associated cost of trying to avoid a pregnancy. But financial barriers can limit birth control options for many women, as you so highly said. Canada currently has a patchwork of coverage for contraceptive, which varies according to income and where you live. This forces some women to choose the cheapest method, not necessarily the most effective or the best method for their bodies, or in some cases they may not be able to afford any birth control at all. This can result in an unintended pregnancy. I see this every week in my practice. We can do better than that for Canadian women. Approximately 40% of pregnancies in Canada are still unintended. This don't just only impact women and their family, but it also affects the economy. The direct cost of unintended pregnancy in Canada is estimated to be at least $320 million per year, a figure that doesn't include the downstream cost to society or to parents. The BC modeling indicates that the health system will save $5 for every dollar they invest in contraception every year. As legislators, we urge you to ensure that Bill C-64 passes smoothly and without undue delay. To fully implement the commitments in this bill, Ottawa will need to negotiate agreements with the provinces and territories, which will take time. Any parliamentary holdup will only force women to wait longer for this much-needed assistance. Already, my patients, my neighbors, my nurses with who I practice every day have been asking me when this coverage will become available, because it's never soon enough for those in difficult economic situation. We also urge you to ensure that the final version of the bill and any budget measure attached to it include coverage of a full range of contraceptives, including the pill, the patch, the ring, the IUDs, the shot, the implant. By ensuring that all options are available, 9 million women in Canada will no longer be forced to make decisions about their family planning based on their income. Thank you.
We will now begin with rounds of questions, starting with the Conservatives for 6 minutes. Dr. Kitchen, please.
Thank you, Mr. Chair, and thank you, everybody, for being here at this late hour and on such short notice. It's greatly appreciated, and I think that's part of what Canadians want to see is true conversations and discussions of what this piece of legislation says and what this piece of legislation means, and being able to decipher it in a manner that the average person that might even be watching this evening at this point in time can understand what is going on and the challenges that we have. To you, Ms. Theriault, and thank you very much for your comments and your insight. One of the things in my past life, before I became a member of Parliament, I was a consultant for the FNIHB. And so I'm aware of things along the lines of providing healthcare services to First Nations in different avenues. I'm wondering if you could explain to those watching who don't understand, because FNHIB is covered by the Government of Canada, and so what you could say on the coverage for diabetes and other coverages that might be available.
Under the NIHB program, correct?
Correct.
Thank you, Mr. Chair, and I thank the constituent for his question. So the NIHB program and specific diabetes medication coverage is more extensive than the formulary list that was the backgrounder list that was circulated. And there are some disparities between the NIHB list and the Canadian practice guidelines that are published. And so they're not fulsome and not comprehensive in the first place if we really wanted to pick them apart, but they are better than the formulary list that was proposed here as a base minimum, and there are some that are only able to be covered if there are specific requirements of such. You need to be an insulin user to get a specific medication covered. So it varies in terms of all of the medications. One big one that we see that is not included is your GLP-1s, and that's something that our Indigenous people use extensively to manage their blood sugars in a way that works for them. And I think that we need to look at it very, very holistically on what it also provides outside of pharmacological care, because pharmacological care, sorry, that's a hard word for me today, is only a certain portion of what is covered under non-insured health benefits.
Thank you. So to be clear, you're basically saying that what's being proposed in this legislation is actually less than what is available for First Nations at this present time, under the understanding also that the services that are provided to First Nations are universal across Canada. They don't vary from province to province.
So first of all, it is for status First Nations and Inuit beneficiaries. So yes, for status First Nations and Inuit beneficiaries, the NIHB program currently provides more coverage. Now we are missing an entire other population of Indigenous people and also our non-status individuals within that scope. So we cannot make a sole judgment just based off that one thing, but yes.
I appreciate it. So are you, and granted you did touch on the fact that because of how quickly this came about, you weren't able to get conversations with all groups. Are you aware of whether actually the government has actually talked to First Nations about this before this piece of legislation came about?
I am not aware, and I wouldn't be privileged to that information in my current role and position. Okay. But I do make it clear that our Minister of Health does need to have those conversations. And
that was going to be my next question. Do you think that's an important aspect where this Minister of Health should be talking to our First Nations before we even get this out on the table?
I believe that our Minister of Health has to have conversations with provincial and territorials, as well as our First Nations, Inuit, and Métis, not just First Nations, governments, and that can be done in a good way through moving the bill forward, and also making sure that, I think the minister said today that he cannot have concrete conversations with the provincial and territorial governments, that he'd be in breach of Parliament or something along those lines. So we want to make sure that the Indigenous voice is heard first and foremost.
Thank you.
And I think everyone can work together
likewise,
towards that.
As you indicated, it should be also for the provinces and the territories to have those conversations.
Of course.
Thank you. Ms. Walker, and thank you very much, and I have huge respect for my pharmacists that I have my own personal pharmacist because of the advice that they provide. And a lot of Canadians don't understand the knowledge base that they have, and oftentimes they are much more knowledgeable on all medications, more so than perhaps even the doctor who's providing that information. And I don't mean that disrespectfully. It's just that that's what you spend 4 years studying to become that pharmacist. Your comment about the committee, and that I find one of the things that I find very discerning about this piece of legislation, because it doesn't clearly define what that committee will be. It doesn't say how many people will be on that committee. It doesn't say what their role will be, what qualifications they need to have in there. And so your comment about having a pharmacist on that in one manner, I think is very important. And I wonder if you could expand on that.
Absolutely. I mean, I think it's very natural to think of your pharmacist first and foremost as the person who's managing your medication treatments on an ongoing basis. And they really can provide a very practical, real-life view of what any changes would propose. So whether the legislation goes in any particular direction, the end result is it's going to be an interaction between the pharmacist and the patient at that counter, right? And so they need to be able to explain what the change has been, why the change has been made, and depending on how the spectrum of the changes that are considered, changing millions of people from different programs could be hugely challenging from just even a logistics and burden perspective. So having somebody like that on a committee would be essential.
Thank you, Ms. Walker. Next, Mr. Joe Harry, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to witnesses for coming. Just want to follow up on what Dr. Kitchen talked about. Just want to also thank you for advocating for pharmacists, one of my very good friends, my mentors, and the one that I trust with all my medication is Akil Dirani, who's running many practices, and I often go to him for advice on many things, especially around the pharmacare. I'll ask you a very simple question. You are familiar with, or I believe you are familiar with the plan, the healthcare plan that we have, okay? And if I develop type 1 diabetes, what would be the scenario today for me? What would be the difference today, whereas tomorrow when this bill passes? What would it be when I go to Akil and say, Akil, now I have type 1 diabetes, but it's universally available now. What change would I see from a treatment? And what change should I anticipate from my insurance provider?
Yeah, so it really depends a little bit on the treatment that you're currently using. We certainly fielded an enormous number of questions from pharmacists when the PSHCP transition was made, because there were changes that affected patients. One of the biggest one was, as some members might be familiar, compliance packaging for elderly people. So that's a service that was provided with an understanding from the pharmacist and the physician that it was noted in the file. But now a pharmacist has to apply, or the patient has to apply, go into their paperwork, get a response back from the plan provider. And so I'm illustrating that just to mention that it can be additional processes to go through. And so the difference might be if you're on a drug that isn't currently envisioned on the list, such as GLP-1, the question will be, will your current plan cover that and pick that up? We're also very familiar with the challenge that employers are looking to cut costs as part of their plans, right? So if it's already covered, if a drug class is already covered, they may look to reduce those costs so that they can invest in other areas of their plans. And so those are the questions that we would ask. And if you're not currently covered, and this is sort of what happened with if you're from Ontario, the OHIP Plus program that was for kids that was introduced, pharmacists had to do a lot of triaging of patients who had lost coverage for a particular drug, apply for special exemptions, and that just adds to the burden of an already existed, very pressured profession and healthcare system at the moment.
So, making it simple, if I am covered today, your concern or the pharmacist's concerns is, would the amount of coverage potentially be reduced because the type of let's say diabetic medication that's made available as part of the universal. That's
Certainly.
one area that you can. The other one is if I don't have medication, I don't have coverage. That means at least I'm one step ahead, being able to get the medication that I need. Is that a fair summarization of what the concerns are and what the benefits are?
We've always advocated that the best way to serve patients is to help fill the gaps for people who don't have coverage or to help people who don't have enough coverage. And those are slightly different issues and need to have really tailored solutions. So absolutely, this could be a step up for somebody who doesn't have coverage, and we would support that. But in terms of the legislation, we would like to see a more explicit reference to maintaining private coverage so that it would go to that private coverage first.
So what would be it? You're going to make one recommendation along those lines. What would that recommendation look like?
We would look to some of the definitions around single payer and specifically coordination of benefit, which is, again, if you have a spouse, you might be familiar with a pharmacist having to coordinate, first apply to the one spouse's plan and then coordinate with the other spouse's plan so that you don't have to pay out of pocket, but to do so with a way that the private plan is charged first and then the public plan picks up the remainder of the difference if there is one. And if you don't have coverage, then the public plan would jump in first.
Okay, thank you. With my remaining time, I'm going to go to the Society of Obstetricians and Gynecologists of Canada. I'm developing an understanding of many different contraceptive that's available and how it fits best depending on the situation. Can you give us a sense? And I think you touched on it. Can you explain further the fact that this current scope is covering a broad range of contraceptive and supporting products? IUD was mentioned as one of the items in one of the panel. I think it's on the first panel. Can you expand how is this helping Canadians, especially women, who want to have that choice to be able to plan their life better?
Absolutely, and thank you for this question because it's really, really important. And I'll give you two quick examples that are easy to understand. In 2006, I was at that time president of OB-GYN Society of Quebec, and we made representation to the government to have the hormonal IUD covered. That was a long time ago, 2006, and in other provinces, it's still not covered. And these methods have been doing an amazing change in the teenage pregnancy rate because they are very, very effective. And once the IUD is there, it's there to stay. Now we can leave it up to 7 years unless the woman wants to remove it. So every one of these methods has some advantages and some side effects that sometimes adolescents or women don't like. And that's why we, by having all medication coverage, it's going to really help us to fit the need. But as you said, because, I have a Canadian position, and my heart is broken when I hear that, because since 2006, we've been putting IUD, and then women are happy, decrease the rate of hysterectomy because there's a lot of good side effects like decreasing the bleeding. It changed women's lives. So that's a good example of what needs to be done.
Thank you, Dr. Francoeur. Thank you. Monsieur Blanchette-Jonca.
You have 6 minutes. Thank you. And thank you to the witnesses for being with us tonight. My question is for Ms. Walker. You mentioned that pharmacare wasn't just about cost, but about the care that is provided. Could you talk about that a little bit more in detail? Certainly. Not all drugs need advice from a pharmacist, and the work behind the counter is very complex, though. Pharmacists can talk to patients about the interactions and make sure that patients have the right medication. They can go over the medication and look at the other medications that are being used by the patients. And more, we know that pharmacists are providing primary care. Thank you. You also talked about your concern about the medications that are covered. We have had a program in Quebec for 30 years, and many are familiar with that. There are about 2,000 drugs that are covered. It isn't all of them, but do you feel it is reasonable to actually examine the concerns that have been raised by doctors and others? A report showed that the formulary used in Quebec was the most complete of any across the country. So the risk of losing coverage for people increases if we move from a private sector to a public sector plan. So we need to look at what the list would be, and if we look at medication for heart disease, for example, for those who don't have it, that might be a good way to go. Do you have any advice to give about not losing coverage? The bill, in fact, is a bit vague about private plans. If there were clarifications, it would be helpful. The minister seemed to be saying today that private plans would be protected, but there's no mention of that in the legislation, so that would be something to improve. I share your concern. I find it a little confusing and a little surprising. It would be better to prevent this problem than to try to fix it after. The federal government has given us an overview of what it wants to do, but what would the impact be on pharmacists, even if we don't have all the details? Yes, we don't have all the details, but I could talk about the time impact. There are going to be major changes that will have to be communicated. The government is going to have to include the cost, the differences between the private and public plans, because pharmacists will have to be able to continue to provide the advice. The difference between the public and private plans is quite significant in Ontario. For example, the dispensing cost is much lower than at the national level. So there would be a major impact in that case. And thank you. On your website, your association indicates that the provinces and territories manage their health systems, and that it would be better to avoid creating a whole new plan, but rather increase coverage for those who are uninsured or underinsured, so that we would have a mixed system. Clearly, the various provinces are at a very different starting point. In Quebec, there is already a plan. It may not be perfect, but in BC, for example, there is no plan. So we think that the biggest impact right now would be to identify in each province how their programs could be strengthened, and because the needs in each province are not the same. When we talk about moving from one type of plan to another, could you talk about the possible problems? Well, I can certainly give you some examples. When we had a transfer in BC to a new type of program, the NHIB lost about 17% of the coverage, and so reforms had to be made, would have to be made to make sure that people don't lose their coverage. We've got OPIP Plus in Ontario that was created to help cover children. People had to come into pharmacies to come into their medication, and then they found out that the medication they'd been using was no longer covered because there was less covered. There was less coverage for what they'd been using. We also are still using faxes in many cases. Thank you.
Please, for 6 minutes.
Merci beaucoup, Monsieur le Président.
Thank you, Mr. Chairman, and thank you to our witnesses who have provided very important testimony. The Quebec system has been talked about a few times. A few hours ago, a major coalition in Quebec representing 2 million Quebec residents called on Parliament to adopt this bill, C-64, saying that the organizations represented, that is, the major unions, health care groups, consumers groups, and others, have said that the current Quebec pharmacare plan does not provide fair and universal access. And in fact, there are deductibles that dissuade people from buying their medication. They can't afford to get their medication. There have been increases in drug costs that have put increasing pressure on people, and in some cases they have lost their coverage. So obviously the pharmacare plan in Quebec isn't working well, and all of these organizations are calling on us to adopt this legislation. So my question is for you, Dr. Francoeur. What does it mean for women to have universal access to be able to ensure their own reproductive health? What does it mean for women when they can't afford the medication they need? The big advantage is that we can stop talking about money in this context. We can talk about the advantages for a given person. We would like to have the same model as in BC, but patches, for example, were not included in the BC model. If there was a bariatric surgery, if there are problems with absorption, then the patch will not be as effective, or other means might not be. Maybe a patch would be the best method. So there are various circumstances which call for different medications in Ontario. Young women were studied, and it was shown that unintended pregnancies resulted because women did not have the choices, for example, for an implant or other types of interventions. And I have worked in Quebec. I I work there, and it is not the case that people have full choice. Women do not have full coverage. It depends on the coverage that their parents have, and and that means that there is an extra step involved in protecting young women from unintended pregnancies.
All of your testimony was very important. I was particularly touched by your speaking about heart and stroke, the 600 Canadians that die every year because they can't afford to pay their medication. And what I hear you saying is that we can't stop with diabetes medication and contraception. We have to move as quickly as possible to cover heart disease and medication that prevents strokes. I know of constituents that are paying $1,000 a month for heart medication that keeps them alive. You have to make that difficult choice every day. Do I put food on the table? Do I keep this roof over our family's head? Or do I stay alive? What impact would it have if universal pharmacare was extended to all the medication that Heart and Stroke Foundation and the research prescribes for people with heart and stroke issues?
It would be very, very significant because, as I mentioned earlier, there is a significant 16%, in fact, of the 1.6 million people that live with heart disease and stroke cannot afford these drugs. And what they end up doing is splitting pills, skipping doses, not renewing their prescription, or not even filling the prescription in the first place. So what happens is, of course, if they don't have proper access to those drugs, they end up going to the ER, and then it's much, much more expensive to treat. So, I understand that Rome was not built in a day, and this first step won't cover necessarily CBD drugs, but in the future we would like to have that covered. But I should mention as well, though, is that someone with diabetes has a threefold increase in the risk of dying from heart disease. So it's an important comorbidity for heart disease and stroke, diabetes. So addressing that as a first step is really key. And if I may, I really would like to address the point of regarding the potential threat that's been raised of loss of coverage through private and provincial plans. The reality is, if the government is providing the federal government is providing a generic diabetes drug, I do not believe that for the person that needs that drug, that they're going to care whether it comes from a private plan, a provincial plan, or a federal payer. As long as they get that generic drug, they're going to be happy, in my opinion. Now, of course, they would be very concerned if we had brand drugs that address adverse effects for them being removed from the private plan or the provincial plan. I can't see that happening. The demand would be really great to have that brand drug coverage in those private and provincial plans. So I don't think it's a very realistic scenario that those drugs are going to disappear.
Thank you, Mr. Orango. Thank you. Next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all to the witnesses for being here today. Celeste, I really appreciated as you were sharing in your testimony talking about doing things in a good way, and it was very reminiscent of the many conversations I've been blessed to have with many of the elders in my region of how the intention has to go and match with the steps. And so the fact that you have been unable to consult with all of your appropriate stakeholders prior to doing that, do you believe that we have put you into a space where you perhaps are not moving in a good way, even just having to be here on such a short timeline?
No, because anytime an Indigenous person has an opportunity to raise their voice and their opinion when it's been chronically neglected through our colonial structures and systems, we must take that opportunity to voice those concerns. And I really, really hope that every bill looks at the Indigenous component, whether that's pharmacare, whether that's any other thing that the House is trying to pass.
And I appreciate that. And I guess what I was trying to ask was, would you have preferred more time to have been able to consult with a variety of stakeholders to assess the impacts of this bill prior?
Not necessarily. We have done an extensive amount of work on talking to people about diabetes through some specific work of Bill C-237 with the framework. NIDA is actually leading the Indigenous engagement for diabetes in Canada regarding that bill. And so we have been having ongoing dialogues ever since I guess we signed with the Public Health Agency of Canada on July 7th, 2022, I believe, and I got to NIDA in October of 2022. So ever since that day, we have been having those conversations, hearing about people and what our healthcare system can provide and what is it current providing, and that is information that is on our website, and it is a report, and that is a first step because we need more, and we're working on that.
No, and I appreciate that. When was your association first consulted on this bill?
So we were not first consulted on this bill. I actually had to make sure that I had a spot at this table to raise my voice. So I will make note that we do have gaps, and I think that I can't comment on all the other pressures that people want to have their voices heard, so I think it's a privilege to be here.
And I'm grateful that you are here, and I am grateful that you are raising your voice, and it's always wonderful to me to have a prairie voice at the table. We don't often have them here in person, so I'm trying not to say anything negative. I'm more trying to figure out, so you had to fight to get here. The government didn't reach out, even though you guys are the leading voice when it comes to diabetes for Indigenous people in this country, and you had to fight to be here. Is that correct?
Yes, but we also have Indigenous politicians and leaders in governments that do some politics work that our organization doesn't necessarily do. We come from that grassroots perspective to making sure that, we're not leaving anyone behind.
Mr. Arango, when was your association first consulted by the government on this particular bill?
So, admittedly, we did reach out to the department, Canadian Drug Agency, Health Canada, to discuss this issue well over a year ago. So, we did initiate the contact, but I think members of civil society, we often have to initiate it yourself.
Could you share who in the department you reached out to a year ago?
So some of the folks that appeared earlier on, sorry I wasn't here, but we did reach out to Michelle Boudreau and her colleagues and others, and we've had quarterly meetings with them. But once again, as I mentioned, we initiated the contact, but that's our job usually as people, members of civil society.
Minister Holland often talks about his experience with Heart and Stroke Foundation. Did you work with him when he was at the Heart and Stroke Foundation?
Yes, many, many years ago. That was 2015, briefly, for 2 years maybe, yeah.
Okay. Have you talked to him specifically about this bill?
Not the minister. I don't, I talk to people in the department, I talk to people in the minister's office, and I talk to MPs, but I haven't talked to the minister directly.
Wonderful. And Ms. Walker, same question. When was your association first consulted on this bill by the Department of Health?
I think I would probably share some of the same observations, is that we engage regularly with the department, and we reach out when we see certain areas. We've been active on this file for many years, and we've discussed it regularly with officials at both the political and department level.
Thank you, Ms. Walker. Thank you, Ms. Goodridge. Next, Mr. Nakvi, please, for 5 minutes.
Thank you very much, Chair, and thank you to all the witnesses for being here, and I really appreciate your testimony. I'm going to start with Dr. Frank Kerr. Thank you for being here. One of the areas that I'm hearing a lot around in my constituency, I represent Ottawa Centre here, downtown Ottawa, is around contraceptives and how this bill ensures that contraceptives are available for women, gender diverse people who need contraceptives, and takes that cost barrier away. I recently had a conversation with Planned Parenthood here in Ottawa as well, and they raised some really important issues as well. From your experience, can you talk to us a little bit about the importance of making contraceptives available the way we're proposing to do, and the kind of impact that is going to have on the lives of women in Canada?
Well, thank you for that question. It's we've been lucky in a way that BC started before, so they've been covering contraception for a year now, and all the good news that we hear about it's obvious that it's making a change. So we're just eager to know all the numbers and the result associated with this coverage. But obviously, money is a big issue, and women. We were talking about the Quebec model. We see that women delayed when they have a part of it, because someone mentioned it in with the prior group. It's still a lot of money. Nothing is free. I mean, in Quebec, don't have any expectation. Nothing is free. They still have to pay a part of the when they go on a monthly basis, and sometimes they wait, they postpone, they want to make sure that they're going to take all the medication at once to pay just the minimal of the coverage. So all of these actions are burden to make contraception less effective and promote unintended pregnancy. And there's a cost for that. There's a cost for the future of Canadian women, because we know that when young people have a baby at a younger age, they're more likely to stop going to school, and this has an impact on all of us, because there's a cost associated with that we all pay as well.
We've been talking a lot about the social impact of having contraceptives available to women and girls. We've talked about examples where a young woman may not want her parents to know that she's using contraceptives, and by using private insurance, there's a notification where the parents may know. And so I think we have a good understanding around those impacts and the freedom that this type of measure will give to women and girls in Canada. Can you speak to, from your experience on the health side, as to the kind of impact this access, by breaking down this barrier, means for the health of women and girls in Canada?
Between 15 to 20% of women have really many problems related to their period. It's going to be hemorrhage, so they're going to be bleeding problem that they are carrier. It could be endometriosis where they have pain. So obviously, when they are on a hormonal contraceptive method, these symptoms are all alleviated. So it's a good side effect of these drugs that we can use. But unfortunately, sometimes they're just not gonna be able to afford them. We had a lot of new immigrant women that are not covered by all our refugee coverage, especially in Quebec in the last year. And I can tell you, it is a burden. They don't have any money. Not at all. Not to pay the cheapest method that they could get. And, an IUD is going to be at least $450, $500. That's a lot of money. It is a lot of money. Even if you keep it for 7 years, it's going to be cheaper. But that makes a big difference. So that's why we want to make sure that these newcomers are going to be able to settle, learn the language, become Canadian, and then plan their family and their pregnancy, instead of being surprised by an unintended pregnancy because they were not able to offer the contraceptive that they wanted.
Do you see a lot of stigma around cultural stigma, social stigma around sexual health of women?
Absolutely. And we are afraid of what's happening at our neighbors down the south, and we think that we have to make sure that all Canadian women will have a right to be questioned and engage in their sexual reproductive rights.
And that's a really good point, because we're so influenced by what happens in the United States. Sometimes that perception becomes, people think that's the reality in Canada. I've heard from so many people when we saw Roe versus Wade being overturned in the U.S. that they thought that was the case here in the U.S., in Canada as well. So we have a lot of hard work in terms of creating that education, that safe space for women, where they can be free sexually.
Thank you, Mr.
From the health perspective, and hopefully this does that. Thank you.
Thank you. Monsieur Blanchette-Chonka pour 2 minutes et demie.
You have 2.5 minutes. Thank you. I want to come back to my questions. Ms. Dr. Francoeur, thank you for being with us and your commitment to help in Quebec. I know that you were for 7 years the head of specialist physicians in Quebec, and you have a great challenge, and I congratulate you on it. I'm trying to understand how we got to this pharmacare plan. I know when you were heading up the specialist physicians organization in Quebec, you were in favor of the plan we had, and we reduced our costs, and we reduced it from 6 billion, we reduced it by 900 million. So, but if we don't increase health transfers, maybe that wouldn't resolve all of the problem. But if we can provide a better pharmacare plan like we have in Quebec, do you not think it needs better health transfers? Well, those are excellent questions that have to be looked into. Nothing is free, and it's the difficulty with Canada. In my work, I work with other countries, for example, England and others, and our system is very complex because we have a federal system. We have the provinces that administer healthcare. We are the last OECD country without a pharmacare plan, and it has an impact on Canadians. Do you know that in Canada there are still women who die in childbirth? Well, thank you. I certainly am not trying to embarrass you, but you have a new position now. You understand the pharmacare plan in Quebec, but what can the federal government do that the Quebec government can't do already? Well, without going into all the details and revealing any secrets, I think that we can certainly look into improving the Quebec plan. We know that a lot of systems are different. In fact, daycare has been a very difficult sell in Ontario, trying to get women back to work by having good system, and we've seen so many emergency rooms have to close. We have to enable women to get back to work. Thank you.
Thanks, Mr. Chair. I'd like to come back to you, Ms. Theriault. Thank you so much for being here. I asked a question earlier about to Mr. Blesky, who is a witness who is diabetic, and what would happen if he was unable to take his medication. It was horrific what he described. I don't know if you were present and heard his testimony. I'm wondering what the impact is. If you mentioned and flagged specifically Métis people, non-status Indigenous people who don't have access to medication right now, what is the impact if you do not have that medication, and what would be the consequence positively of having a large number of Métis people, non-status Indigenous people, actually getting access to all of the diabetes medication and devices that they're prescribed?
Yeah, thank you, Chair, and through you, I think the question. I think it's important to note that I don't live with diabetes, although it affects many of my family members, and we are Red River Métis, and so what I see in my personal network of my family is that people, they don't live with type 1, and I did hear the testimony earlier today, but they do live mostly with type 2 diabetes, and it's extremely hard to get a CGM covered when you're under type 2 diabetes, by the way, but that's what we know is causing so that you don't get your calloused fingers, so that, if you have a desk job and you're typing all day, you're able to just check, monitor, you have better in-range time of your blood sugar levels, but also we see it in insulin, because some people will insulin ration as well, just to make sure that, they can put food on their table. And I don't think that's a choice that people need to make when it comes to their health. And I think that people should have access to the things that they need in a timely manner for them to be able to manage their health in the way that they need. And that's Métis, non-status, status First Nations, Inuit beneficiaries, all encompassing.
How many, do you have an estimate on how many Métis people, non-status Indigenous people would be helped by having this universal access that can't access it now through the NIHB, of course?
So I don't have specific numbers, but I have some percentages here in front of me. And Métis, and this is some older data because we struggle with some data points and data collections and gathering data from some governments sometimes. So it's currently at 7.3%, but let's be clear that that is some 2010, and that on the most recent 2022 Framework for Diabetes in Canada report did state that it has found an increase in the prevalence of diabetes across all Indigenous populations since 2012. It didn't specifically outline the percentages. So Métis was 7.3%, and the we don't have the non-status because they get lumped in with non-Indigenous people because they're not recognized under that. But I would refer to probably some of the organizations that do work on behalf of non-status people to answer that question, and I can make some inquiries to see if we can get some answers like that.
Thank you, Ms. Theriault. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair, and thank you to the witnesses for being here. Ms. Walker, you're a pharmacist, and you're still working as a pharmacist. Is that true?
I'm actually not a pharmacist, a practicing pharmacist. I work for the Pharmacists Association and with those members to navigate some of the issues that they encounter in their work.
Great, thank you for that. One of the things that's not captured in Bill C-64 is something Canadians have relied on now for many years, and of course that's the expanded scope of practice in the professional life of pharmacists. And is that something that you think should be captured in this bill?
Absolutely. I think there's many services that pharmacists are delivering now to Canadians across communities. In many rural and remote parts of the country, the pharmacy is the closest access point that they have to health care. And so pharmacare, as we sort of mentioned, isn't just about sort of like the cost of the drug, but really the care that goes around it. It'd be like dental care without dentists. And so we absolutely see that. And increasingly, pharmacists are doing a lot more to serve their communities.
Well, I was going to say something smart, but there is a dental care program without any dentists. So anyway, that's a whole other issue. It's interesting, though, especially when we're talking about diabetes, because, of course, many pharmacists are diabetes educators, which helps diabetics better control their blood sugars. And often there is a cost now built into provincial plans and private plans to pay for that. But this bill in particular doesn't capture any of that cost. And do you think on behalf of your members that would be an important piece to have as part of this legislation?
There are a number of different services that are associated to drug management. So clearly there's the dispensing aspect that, makes sure that the person is getting counseled, that they're getting their drugs safely and effectively, that there's no drug interactions with other things. And then there's things like medication reviews for people who, might be on multiple medications, and appropriate use is really important. We know that many aging Canadians are taking medications to address a side effect of another medication. And that's an unfortunate way to live. So for certainly smoking cessation, diabetes management and care, hypertension, there's been a lot of evidence showing that those services provided by pharmacists actually improve the quality of life of Canadians and also the use of those medications.
Now, It's interesting, Ms. Walker, you talked about looking at the plans and this concept of universal single payer program that's introduced here in this bill. And in your experience on behalf of your membership, would you suggest that that would mean that the federal government would be the first payer? Is that not true?
Some of the questions that we've so far heard and have posed ourselves is how that's interpreted in the legislation, and I think for what we're looking to see is a clearer definition of which payer would come in and whether there will maintain a private payer. And I think a number of the provinces that have spoken publicly on this issue have also raised that they would be looking to add to their current public plans, but while maintaining sort of the private aspect that they have in their jurisdiction. So really would come down to some of the negotiations that would take place. But the legislation, we would recommend that there be clear reference to a mix of public and private payers to make sure that that's maintained looking forward beyond even diabetes and other potential medications that might be under consideration.
So what I've heard you say is that would be an incredibly important part of our rapid deliberations, which must happen by Monday in our clause-by-clause consideration of this bill.
Yes, I think we would support that, absolutely.
Great, thank you. One of the things that has been talked about here in this last panel a bit and in previous panels is semaglutide or Ozempic, which is a drug obviously used to treat diabetes. It's been an absolute blockbuster drug. Do you have any information for the committee with respect to the cost on a monthly basis of Ozempic or semaglutide?
I don't have that number handy, but I will share a couple of examples that might be helpful in your deliberations around Ozempic. It's obviously not covered under the proposed list of medications that's widely used. We've recently had a shortage of Ozempic across the country, and my association works very regularly to address shortages that are a growing problem in the country. So when we talk about pharmacare, it's not just about the cost of drugs or the services that are being offered, but if that medication is not available in the country, there's no amount of coverage that's going to help that. And one of the things that we've noted certainly is the number of available medications in each drug classes can decrease significantly depending on how many companies are on the market, and we are most vulnerable to drug shortages if we only have one or two manufacturers producing a particular drug. Say if there's like a national disaster in one country that's producing some of the API and the one company can't produce that drug, the other companies aren't able to readily increase their production, and we've really suffered significantly with many shortages. So there's a really complicated, I think, ecosystem that this pharmacare approach needs to also recognize.
Thank you, Ms. Walker. Dr. Ellis, the last round of questions for today will come from Ms. Sidhu. Next 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being with us. My first question is to Ms. Torrio. With the dental program, we know the 100,000 already within 3 weeks Canadian get benefit, and then 1 million already registered. But with this legislation, could you elaborate what are the biggest barrier are the Indigenous people seeking care for the diabetes prevention? And with this legislation, what do you think with the contraceptive care? Do you think it will be benefit to the Indigenous people?
Yeah, certainly there's going to be benefit to Indigenous people, and that's without a doubt. I think to comment on your first question is that we need to also ensure that we are making holistic, with a W for the note takers, decisions around public policy that affects our health, that doesn't just look at, the pharmaceuticals and all those things. And I know we're here specifically for the pharmaceuticals, but there are so many other things that impact that, socioeconomics, social determinants of health. And so I think this is the first step in a right direction for, opening up the conversation and the dialogue to all of those other sectors that obviously this bill does not cover. And of course, Indigenous people, if their medication cannot be covered, most likely cannot afford to even take the medication. They may not even just get the prescription filled, as we know. And I think that'd be interesting data to look at, as well as making sure that, they're going to feed their family first or do whatever they might need to do first for their own health. And often we're faced with that every day, that decision and that hard decision. And if you place yourself in, I know my chair often speaks very openly about the ideal type of diabetes treatment for herself as a type 2 person living with diabetes in Alberta is currently not available to her because of the lack of coverage, and it simply would be way too expensive for her and her family of 6 children to afford. So therefore, it is just not an option, and she has to look at other alternatives.
Thank you. And my next question is to Dr. Franker. Dr. Franker, you talked about the teen pregnancy and sexual reproductive health. So could you outline what the biggest barrier are for Canadians seeking contraception, and what would you recommend to combat this?
Well, first of all, I think that cost is definitely one of them, especially choosing the long contraceptive like the IUD, the patch, and this is the finance around it is really the biggest one. But second, there's something that we don't talk enough. Also, it's the coercive aspect of contraception. You know, a woman will pay for 30 years, and if she doesn't have money to pay herself, it's going to be her partner who hopefully should share part of the bill. But we don't see that. So unfortunately, when once again money is being brought during the conversation on which method they should choose, it has an impact. So if women are allowed to make their own choice and they don't have to beg to have help to pay the contraceptive method of their choice, that's going to have a